Sometime within the next year, a surgery will be performed at UW Medical Center that is so advanced and still so rare that it's only been done 30 times around the world. It's a procedure that, in the words of the surgeon who will head up the operation for UW Medicine, is not so much life-saving as life-giving.
These patients have devastating injuries. They're reclusive. They have no life. They can't go out in public. They can't eat in public. They can't do anything. And most of them not only can't, but just don't want to. They don't want to be seen anywhere.
Today on the UW Medicine Pulse podcast, both the technical and the ethical challenges involved with face transplant surgery.
This is the UW Medicine Pulse with Marty Riemer. Real-world stories of the discoveries being made at UW Medicine and the impact they're having on people here in the Pacific Northwest and around the world.
My name is Peter Nelligan. I'm a professor of surgery, and I'm director of the Center for Reconstructive Surgery at UWMC.
In addition to the many diplomas, certifications, and awards that adorn the walls of Surgeon Peter Nelligan's fourth-floor office at UW Medical Center, hangs a framed recent Seattle Times article. It's prominently displayed right next to his door and is a sign of just how much this story means to him.
While I was waiting here in your office, I noticed this article in the Seattle Times. Is this an exciting time for you? Or maybe exciting, I don't know, isn't the right word.
No, it's an exciting time.
It's a story about how UW Medical Center is now one of only 20 hospitals in the U.S. and the only one in the Northwest to have been approved to perform hand and face transplants. Yes, face transplants.
What does it mean to transplant a face?
It means to take the facial tissue, which includes the skin, the subcutaneous fat, the muscles, the nerves, sometimes the underlying bone, depending on the reconstruction you're trying to achieve, and taking it from a donor and transferring it to the recipient.
If that sounds futuristic and even sci-fi-ish, it is in fact still a very advanced and rare procedure. The first face transplant in the world was done in France just 10 years ago. Since then, 30 have been done, 10 of those in the U.S. As Director of Reconstructive Surgery at UW Medicine, Peter Nelligan heads up a team preparing to do the very first face transplant in the Northwest.
Face transplant is actually called VCA, which stands for vascularized composite transplantation, or a vascularized composite allotransplantation. And that means you're transplanting composite tissue, which usually it consists not just like a liver transplant of a solid organ, a piece of liver, but it consists of
skin, muscles, nerves, bone, blood vessels from one person to another.
It applies to face transplant. It also applies to hand transplants.
Face transplants are designed for patients that have suffered devastating, disfiguring injuries.
And these patients are generally reclusive. They can't go out in public or don't want to go out in public. And there are all sorts of injuries and conditions that cause this sort of deformity. Burn injuries and some conditions. The commonest condition that we see that would require this sort of surgery would be patients with a disease called neurofibromatosis.
He is English. He is 21. His name is John Merrick. At no time have I met
Joseph Merrick, the Elephant Man, was thought to have had neurofibromatosis, a disease that leads to severe disfiguration. As you might imagine, a face transplant is a complex procedure, not just the operation, but everything surrounding it.
The techniques that we use in the surgery are techniques that we use for lots of other reconstructions. But what the big deal about it is that the patient needs to be on lifelong immunosuppression.
All transplant patients are on lifelong immunosuppressive drugs. But the difference for a face transplant recipient is that
it's a big ethical question, because ethically it's fine to take the risk of being on these drugs if you are going to die because you need a heart transplant or a liver transplant. But you're not going to die if you don't have a face transplant. And so the ethical question is, should these patients be given immunosuppressive drugs? Because immunosuppressive drugs can lead to a greater incidence of infection. They can lead to a greater incidence of cancer. They can essentially shorten your life. Some suggest that they shorten your life by about 10 years. I spoke to a patient recently who said, well, so does smoking. So it's a balance.
That's why finding the right candidate for a face transplant procedure requires a very rigorous screening process.
The first part of the screening process is to have them evaluated by a psychiatrist who's also a member of the team, Dr. David Au. And because these patients are very complex from a psychological and psychiatric point of view, and they're going to need a lot of support after the transplant for a number of reasons. And so we need to make sure that before we embark on a transplant that they're going to be capable of that, and they're going to be robust enough to be able to go through all of that.
Once the patient clears the psychological screening, they meet the rest of the UW Medicine transplant team. And then the team holds what's called a listing meeting, where together they discuss and decide whether or not they have indeed found a good candidate.
And then we officially list the patient. Once the patient is listed, then that's really telling people that this guy is ready for a face transplant and we need a donor.
And that opens up another whole list of challenges.
Face transplant is different to other transplants because if you're transplanting a heart, for example, then you want to make sure the heart you're getting is healthy, and you do a whole bunch of blood tests to make sure that they're a tissue match. But with the face, it's a lot more, because you have to match not just tissue, but you have to match ethnicity, you have to match sex, you have to match approximate age.
Face transplant is also different because it's a face. And society hasn't really, except for maybe in a Hollywood film or two, contemplated the idea of donating one's face.
The fact that you are a donor, an organ donor, and have a driver's license saying that you're an organ donor doesn't qualify you for a face transplant. Face transplant is separate.
Is that because face transplant is much newer?
I think it's partly because it's much newer, but also it's in many ways it's much more intimate. Because if you take somebody's heart or somebody's liver, you're not going to see it again. Whereas somebody's face, you are going to see it again. It's not going to be the same face, but it's going to be there.
Well, that brings up a question that I'm sure you get asked an awful lot, and that is, when you transplant the face, do you transplant the look?
No, you don't. You transfer the recipient ends up as some sort of hybrid between him or herself and the donor. They don't look quite like themselves. They also don't look quite like the donor. So somebody who's had a face transplant walking down the street isn't going to, be recognized as...
At all.
At all. Right. I mean, the only reason they would be recognized is because they've been on TV and people say, oh, there's that guy. But friends of the donor or family of the donor wouldn't recognize their loved one walking down the street at them.
And why is it that they don't look like they did before?
Because a lot of the structure is different. A lot of the face transplant is just the soft tissue, and even though the bone is transferred in some patients, that bone is fit into the recipient's bony skeleton, so that the whole structure of the face is different. So it's like having a building that has a different exterior put on it. It doesn't look the same as the old building. Or if you take the exterior of one building and put it in another building, it's not going to look like the old building. It's going to look like something different.
You talked about some of the challenges that the recipient of the face transplant undergoes with the immunosuppressant drugs. What about as a surgeon? What challenges do you face?
Well, there's the technical aspect of the surgery. It's a long surgery. Sometimes it can take 15 hours. Sometimes 25 hours, sometimes 30 hours. And so you kind of need to pace yourself and be prepared for it. Usually and what we're planning to do with the face transplants is that once we have identified the patient or patients who are going to have transplants and we know exactly what operation we're going to do on them, then we'll practice that. The whole team will practice that in different ways so that on the day everybody knows where they're supposed to be and what they're supposed to do.
Because on the actual day, time will be of the essence.
Because what we call the warm ischemia time, so what that means is that when you take a piece of tissue like a face from a donor and give it to a recipient, it's going to die within about 4 to 6 hours. So the transfer has to be done within 4 to 6 hours. And so when you're harvesting the face, the last thing you divide is the blood supply. And then you transplant it to the recipient's blood supply as quickly as possible. And then you do all the rest of the stuff. Once the blood is flowing, then you're fine. But you've got 4 to 6 hours to do that.
Face, and for that matter, hand transplants are complicated operations because the surgeon has to reconnect blood vessels, nerves, and muscles so that the face or the hand works. So the recipient can, in the case of face transplants, smile, blink, and feel.
Eventually, not at first, but yes, eventually. And the degree of recovery is variable. If you look at the 30 patients who've been done so far, some have better movement than others. And a lot depends on a number of factors, because the nerves have to be joined up, but sometimes it can be very difficult to find nerves. And somebody who's had a devastating facial injury, their nerves may not be easily found. And so while we'd like to join up all the nerves, sometimes you can't because you can't find them.
There's that variability. There's the concern over rejection. There's the concern, as Dr. Nelligan mentioned earlier, over the immune suppressive drugs themselves. So you have to ask, is it all worth it? To answer that, Dr. Nelligan often says that these procedures aren't life-saving, they are life-giving, which means
these patients have devastating injuries. They're reclusive. They have no life. They can't go out in public. They can't eat in public. They can't do anything. And most of them not only can't, but just don't want to. They don't want to be seen anywhere. And you give them a face transplant, and it gives them their life back because they can now go out in public. They can go to restaurants. They can go to the movies. They can, do all those things.
Dr. Nelligan has a presentation he gives about the UW-Medicine face transplant program. As part of that presentation, he tells the story of a Frenchman whose life was transformed by one of these surgeries.
And this is the patient that I showed you before with the neurofibromatosis in Paris. And this is him. This is shot by French television. And he's window shopping in Paris just before Christmas, before his transplant. And you can see there's some kids here who are looking at him and pointing and staring and laughing at him, and the mother's kind of pushing them away. And he's saying, well, that's just, part of the deal of my handicap. And it's just kind of normal for me. So, he couldn't go out in public without people looking at him and staring at him and often laughing at him. And this next video is exactly the same place a year after his transplant, doing exactly the same thing, window shopping. And you can see he's just standing in the crowd, nobody's giving him a second look, and basically he gets his life back.
Sometime in the next 12 months, Dr. Nelligan and his team at UW-Medicine will perform that first face transplant in the Northwest. They've received the necessary approvals, and they've received them in large part because
we have everything here, basically. We have a very good transplant program in existence, so we don't have to build anything. And we have, excellent support from the hospital and the university, so everybody's kind of behind this.
And like other organ transplants, it's Dr. Nelligan's belief that in time, face and hand transplants will become equally as accepted and commonplace.
And the big block to it right now is the whole immunosuppressive thing. But it's the only way we can transplant patients right now. However, there's a huge amount of research going on how to change the immunosuppressive regimes that we do, and how we can suppress somebody's immune system without putting them at risk for infection and cancer and all of those other things.
And once immune suppression becomes safer, the uses for this type of transplant procedure, well, you can imagine. And Dr. Nelligan already is.
There are a lot of servicemen who are coming back from theaters of war with injuries that would have killed them years ago, but body armor has improved so much that they're now surviving those injuries. So we have a lot of soldiers coming back with arms and limbs blown off or faces blown off, and they're alive, and they need something. And right now there's nothing for them until this came along.
I want to thank Dr. Peter Nelligan for joining us on this episode of UW-Medicine Pulse. To find out more about his transplant work at UW-Medicine and to find out more about organ donation, go to our website, uwmedicine.org/pulse. And while you're there, you can subscribe to our podcast via iTunes and get each and every episode of this show delivered to your phone or tablet for free as soon as they are released. UW-Medicine Pulse is produced by Tina Knoll, production assistance from Aaron Gervais. I'm Marty Riemer. Thanks for listening.